Hello, it's Nick Knight here, Podiatrist Director here from NK Active. So we've just recorded our latest NK Active podcast with Dr Jill Halstead. It was a really informative, great episode chatting all things arthritis. However, Jill halfway through had some Wi-Fi issues, we had to turn the video off and we lost a bit of some of the sound. Because the content was so good, we still want to put it out there for everyone to listen to, but I just want to reassure everyone that we are going to get Jill back on the podcast at a different time. So enjoy the episode. Please do subscribe to the podcast, and any questions, just let us know. Hello and welcome to another episode of the NK Active podcast. We've got a fantastic guest for this episode, Dr. Jill Halstead. She's a podiatrist and clinical and research lead up north. I've known Jill, I can't remember how, it must be at least 10 years plus now. I can't remember. But Jill, sort of give us a background, a bit of an intro and a background about yourself.
Yeah, thanks, Nick, and thanks for inviting me. My name's Jill Halstead. Like Nick said, I've been a podiatrist for 20 years. I started out in a dual role with research, always been an interest of mine, and I was part of a national internship scheme when I graduated in 2003. And I've worked in lots of environments. I've worked in the NHS, I've worked in private practice, and I've worked in hospitals as well as community, so lots of different settings. And my research is mainly being in community and in hospitals around rheumatology, so that's different types of arthritis. That's why I'm here talking to Nick today.
It is, and the work that you were involved in is most probably one of the first bits of research that actually made a big difference to my practice. And I remember telling you, so I remember getting excited because as a researcher, you're always excited when actually you do some research and it actually makes real life difference. And it is the one bit of research that I consistently use on a regular basis, and that's to do with strength through the inside of the ankle and midfoot osteoarthritis. And you basically found if someone has arthritis in the middle of their foot, they tend to have reduction in strength around the ankle, on the inside of the ankle. And when we test that in clinic, we find that every single time they have that reduction in strength. And then we then work on helping them get stronger. We then retest the strength, the symptoms are settled, and the strength is shot up as well. So that was the first bit of research that really made a big difference to us in practice and still use it today. So talk us a bit about...
Oh, thanks, Nick. Yeah, that was some work we did with John Arnold, who's also a researcher from Australia. He came over to Leeds to work with us on midfoot osteoarthritis. We've done some previous work showing that if we supported the arch, some people respond to that really well who've got some midfoot arthritis. But I think there was a lot of confusion around what's the implications of having some weakness around the foot and ankle. When you have arthritis of the foot, I think people assumed it was kind of more passive than that you're just loading, and it was a lot of the research was focused on load and what's happening at the bone level and not so much happening around the muscles. So yeah, that was a really good piece of work that we did with John around the little muscles in the arch of your foot and also the big muscles that come down from the knee and the medial side. And yeah, we used a dynamometer, which is something like a machine you can push against to see how strong you are in those muscles. And I think Nick's really taken that forward, and you use dynamometers quite a bit in your private practice, don't you, Nick?
Yeah, we've been using the dynamometer rule for about 8-9 years now in clinic. Yeah.
Great. So we were just talking about the research used a dynamometer, which is where you can push against this piece of kit that tells us how strong those muscles are. And there's been some great developments in there, and that you can use different adaptations that allow us to look at the strength in the foot. And like Nick said, he uses that in his clinic, and that's something that we used as part of the research. So it's a really clinically friendly piece of equipment. And if you're a patient and you have, pain and or swelling or redness or heat changes or color changes in the middle of your foot, particularly on the top, going to a clinician like Nick and others who have these bits of equipment that can help us understand if you've got weakness there, and also we can show that if you come back, we can check to see how the exercises are working, which I think is really important because, like we found as part of the research, that whether you're strong in that part of your foot around the arch is really important as to how that relates to pain, how severe your pain is, and also, like Nick said, about how you have potential improvements over time. So I think this is a really nice example of where research comes into practice that, Nick has obviously been so gracious about and telling us that it really helped him. And I think there's that potential to help you as somebody with arthritis and as a clinician who deals with these kinds of arthritis in the middle of the foot.
And I think that also then builds onto you mentioned it also, other bits of work that you were involved in that we know from the literature that when you talk about managing, say, midfoot osteoarthritis, if you improve the strength, that can help symptoms. But we also know that having something that can support the arch of the foot can also help symptoms, or a possible slight rocker shoe can help offload the foot as well. And I think you're involved in some of that research as well, weren't you?
Yeah, so we did the first study looking at whether you can put something inside the shoe to support the arch with midfoot osteoarthritis. It works really well in early cases, particularly where the arch of your foot is sat really nicely onto an insole. So it's important to get a really good fit around that. Some people get away with buying things over the counter, but it's really important that your arch neatly fits over it. So seeing a professional is beneficial. So that we showed that did help people. Where you've got more advanced osteoarthritis and you maybe got bony lumps over the top of your foot, you have to be a little bit more careful because you can push those bony lumps into your shoes, and some people get real pain over the top of their foot when they've got more lumps and bumps over the top of their foot when it's associated with arthritis. But we can, Nick and I and lots of people can really help with that. We can tell you how to lace your shoes and give you advice over how we can accommodate that. But for some people where it's really inflamed, and what we do know about midfoot osteoarthritis, it is more susceptible to being inflamed, is that sometimes you need to go to that next level. And some people who don't do well with either the, supporting the arch or strengthening it, some people do end up sometimes with an injection. And we do know if we can settle that down, people do better with the other therapies. But we tend to reserve that for people who are quite advanced or just it doesn't seem to like calm down. In your experience, Nick, do you find there's many patients like that, or do you tend to get the early cases?
We'll tend to either get really early or really advanced.
Right.
So we'll either them really early, and we can then tend to the orthopods, the orthopedic surgeons, or the rheumatologists, or the sports medics or GPs will pick it up early and then send them to us, and then we can then generally manage that quite well in clinic. Or we'll see them where they've got really advanced osteoarthritis and they're looking having to go down the surgical option, and they want to see have we sort of dotted the I's and crossed the T's, as it were, with it. So since we've been working on sort of taking your research into practice, a number of referrals for injections and surgery have dramatically reduced, but we still see a number of patients where actually the arthritis is so severe that actually they end up having to go down the surgical route. But luckily, that number is getting smaller and smaller.
And that's fantastic, isn't it? Because we kind of, we've had quite a lot of things that have helped us understand like big toe arthritis for many years. But I think the midfoot, particularly when I started researching it, and that was first in my master's around 2008. I think there wasn't a lot of information. I think people really concentrated on weakness at a tendon that you have around your ankle. And there was a lot of research, and still there's a lot of research looking at the weakness of that tendon, but not really thinking about how muscle strength generally at the foot and ankle is just really important for arthritis. So yeah, I think it's good to hear that it's had really good outcomes for your patients. And I think it's about getting the right combination. And also, people feeling like they want that change and they're able to invest in that and do the exercises. Because as we know, it's really important to stay active and be present and be part of your life and your daily activities. And if we can promote that as part of that management of arthritis, I think that's brilliant. And getting generally stronger, as Nick and I both believe, health and strength and well-being is really important. So I think generally just keeping strong is a good thing as well, isn't it? And I know you've been a strong advocate of that a long time.
Oh, without a shadow of a doubt. And we've seen a change since we've sort of in that post-pandemic era now, as it were. in that people want to be more proactive. And even the World Health Organization, haven't they? They've updated their guidelines saying that we should all really be doing 3 strengthening sessions a week on top of our cardio-based stuff. Because we know not even just from an osteoarthritis viewpoint, but we know even from a falls prevention viewpoint, from actually life expectancy viewpoint, actually being strong and active has so many positive attributes and benefits to it. And even down to managing your own mental health. We know that exercise quite often is such an effective tool in managing just how we feel. So the way we sort of like phrase it to patients a lot of the time is a case of, okay, we can't guarantee that by getting you stronger, we're going to resolve all your symptoms. But it's almost like the worst that's going to happen is you're going to get a bit fitter and stronger, which isn't really a bad thing.
Yeah.
Even if you got to go on for more interventions like injections or surgery, I'm a big believer that if you go into those fitter and stronger, you tend to get a better outcome anyway. So it's one of those things that it's there's not much to lose, I feel, in just getting that little bit more active and a little bit stronger.
Yeah, and I think, and that's what I'm saying. It's the general trajectory of that. I mean, if you're a person with foot pain and you're listening to the podcast, think about that. How many heel raises can you do before getting tired or achy? How strong are your calves? And if you're feeling really weak, it's important to think about that and why, investing in your health is really important and getting yourself strong. So even simple things like that, understanding what your baseline is, because what does happen over time is what we have to recognize is your muscles just get weaker over time and they take a little bit more maintenance as we age. So that happens slowly in men because of the hormones like testosterone, and in women it can happen slowly or quite sudden depending on the menopause, where our muscles don't work quite as effective and we have to work harder to maintain muscle strength. And it's something that we do have to be aware of, that it does change our lives. We're not quite as robust and uh, yeah, able to just take on exercise or long bouts of exercise we once did when we were younger. And I think it's just like you say, Nick says, it's really important that we focus on the benefits of that. So yeah, I think it's good for us to understand like how we age and how we age well as well.
And it's something that I know we have some of our patients that listen to this, and so they will know that we quite often in clinic draw sort of muscle strength and age and what happens over a human's lifespan. And once you get to a certain age, strength naturally is declining. But the silver arrow I always say is that, well, as long as the heart is still beating and you've got blood pumping around your body, if you give the body the right stimulus, it will respond in a positive manner. We know from the, don't we, from the work from New Zealand where they got
Mhm.
people with osteoporosis in their 70s lifting weights off the floor, reversed the osteoporosis process just by being a little more active and a little bit stronger.
Yeah.
Um, we know it just has so many benefits. And Dave, our rehabilitation instructor, who's been on the podcast many a times, always speaks about that to do that, you don't always have to use a gym setting. There's plenty of stuff you can do around the house on a regular basis. There's plenty of load and weight that you can add around the house to actually start making some positive changes. It doesn't have to be hitting the gym 3 times a week. There's lots of things you can do just while boiling the kettle, while brushing your teeth. If you start doing that consistency on a regular basis, you can make a big difference, can't you?
Yeah. Yeah, and that's the great aspect, isn't it? Like you say, it's understanding what you can do for your health and well-being, so you feel like it's positive for you. And I think that's just a really nice message. I think the other thing that we also want to talk about is just what to look out for where you think things
Yeah.
might not be quite as simple, such as things like osteoarthritis, which we'll all get to some degree as we do age, because it is a component of aging, although that's not the only component. But it's also good to look out for other things and what to do in those scenarios. So it'd be good for us to maybe touch on that as well, Nick, I think.
Yes, especially because we've spoken a lot about osteoarthritis in the past, but we know that so if we stay on osteoarthritis for a little bit, and then we can then look at moving towards other forms of arthritis to look out for. But Jill, did you want to sort of show us if someone's thinking they got more? osteoarthritis, what are the sort of things they will be experiencing, looking for, really?
Yeah, so things that to be aware of with osteoarthritis, if you're thinking it's in your foot, is you generally have patterns of pain with load and weight bearing. So thinking about going up and down those stairs, thinking about going up hills, thinking about walking through those distances, you may not get pain immediately with standing, but most people, particularly if it's in the midfoot, they get pain as they push off onto the toes. They find stairs a bit more challenging, they find hills a bit more challenging. Um, so you tend to find it's definitely more bone and bone movement type pain. You don't tend to get much pain at rest unless it's quite inflamed. And if it's inflamed, you'll see change in your skin tone. So if you have a lighter skin tone, you might see more redness. If you have a darker skin tone, it might look more purple or might look more grey, but it'll go darker. If you have swelling, you might feel red and you might get some heat around that swelling. And if it's at the midfoot, it'll be on the top of the midfoot, right in the centre. So level with the middle of your arch. Sometimes you can get this with other tendon problems, which means it can ache a little bit more and throb, and that might be behind the ankle. But generally speaking, bone pain will feel, like I say, it's more with weight and weight bearing. And that's what we found is most people describe that walking pain, and that it generally got better with rest. But if they tried to progress and walk through it, it kind of stabilized, but it didn't really go away. So it doesn't generally improve with exercise like other tendon problems can sometimes, or heel
Yeah.
pain. It really gets worse and people really struggle. And that's when they can become very self-limiting.
So that's osteoarthritis. The other thing we may have in clinic, and you may see it as well, and we see it more in men than we do women, but it is people coming in thinking that actually, have I got osteoarthritis or have I got gout, for example? So how would sort of gout present slightly differently to osteoarthritis?
Yeah, so osteoarthritis generally likes to come with friends. So, what we mean by that is you're more likely to have osteoarthritis if you have other medical conditions. And they talk about these medical conditions being under a banner called metabolic conditions. And they can be things like high blood pressure, high cholesterol, carrying excess weight around your tummy, also having things like diabetes and pre-diabetes, where your blood sugar is a little bit high but not too high, and they all like to come together, and that generally affects people more around their midfoot when they come with that collection. And then the other thing that likes to come with that, as like I say, osteoarthritis likes friends, is gout can also be associated with that kind of metabolic condition. And so people who complain of gout can seem very different to osteoarthritis, but you can get them at the same time. And gout can appear, it's very common at the big toe, and that's probably where most people know, but it can occur at the midfoot. And I have seen midfoot gout in private practice. Generally speaking, because it's not so bad, you feel like you've got a fracture, but it feels bad enough. And it will feel like it's swollen. It'll feel like it's a lot more inflamed for longer periods. It doesn't seem to go on and off more like osteoarthritis. It's more consistent. It comes on very suddenly without rhyme or reason, despite you've not maybe done a lot of exertion or done a lot to aggravate it. And probably the big difference is it'll affect you more at night, gout. So people that feel very uncomfortable when they go to bed, whereas generally with more rest, your midfoot osteoarthritis feels better. Gout will feel worse at rest. So these are all things to look out for. And also if it's in lots of regions, not just one. So gout generally likes to come in one joint, but it can affect in multiple joints. And there are other factors that you need to be aware of. If you take water tablets, you're more likely to get gout. So that can be a risk factor. So just to be aware of that.
And what about then with gout? A lot of people think it's heavily related to alcohol consumption.
Yeah, that is a risk factor, particularly quite heavy amounts of alcohol. What we do know now, because there's a lot more genetic studies, is there's a definite genetic susceptibility with alcohol and gout. So some people have a very low tolerance for having alcohol and can still get quite severe gout. People always thought it's like the more you drink, it's like that consumption idea from the the 18th century, that the more you drink, the worse it is. But actually, some people have a low tolerance. For instance, if you've got any Japanese heritage, they have a low tolerance for alcohol, but they have gout in much higher rates with lower tolerance. So it doesn't necessarily always come with that, but alcohol is a risk. High protein diets, so you will get them in people if you're into your bodybuilding. So thinking about your high protein diets, that is a risk as well. You might have a high protein diet for other reasons, but it is something to consider. So people who really go out for like high protein diet, in like they'll eat lots of meats, but they'll also have these high protein bars plus drinks. So it's adding and adding and adding. So just having a good protein diet doesn't necessarily mean you'll get gout, but if you eat, everything's very high protein. So if you're in that very high end athletic world, it's something to really be thinking about, because that's not good for your kidneys, and gout's linked with more of your kidneys and how. So if you haven't got kidneys that work very well, you can also be at risk of gout.
No, and we had a case in clinic recently where we had someone come in. I suspected midfoot, gout around the midfoot and also the ankle joint, and yeah, we sent this person off to rheumatology and sports doc, and yeah, we did find out that it was gout, and they were surprised because they're like, it normally affects the big toe. Well, the big, as you've already said, the big toe is the most common joint, but it doesn't mean it always happens in the big toe joint, does it?
No, and what we do know, gout, although it's very, very uncomfortable and not very nice, it's the only reversible arthritis. It's the only arthritis we know that we treat it very well, it'll do very well. So it's the only arthritis we can treat with effective drugs. With osteoarthritis, as people know who are on this, listen to this podcast, they've tried painkillers, they've tried anti-inflammatory. They don't always work all of the time effectively. They can help for sure, but with gout, we do know we've got a good prevention drug that'll take down the levels of urate which are related to gout in the blood. And we do know that we have good effective treatments for when you get these, what we call like gout flares. But it's really manageable, and with lifestyle changes and good medication, you can do really, really well. But it's something that we can't leave too long, because it can cause quite a lot of change to the joint if it's left indefinitely. And some people, I think, they're not quite sure it's there, or they leave it for too long, and it can cause damage at the joints. So we always say, if you think it's gout, make sure you act quickly.
And it's unfortunately, it's one of those things, isn't it, that once the damage has been done to the joints, then that can't be reversed, isn't it?
Yeah, unfortunately, because gout, it's basically like little crystals. It forms in the bone. So once they formed, it's really hard to reverse some of that. Although some bony changes that happen when you're younger, you can do quite a bit better with as you get older, in that your bones actually do replace themselves entirely. It takes about anything from 1 to 7 years to replace your skeleton. But once you've had that damage with gout, it doesn't have as good reversibility as other areas. Whereas we've shown, if you have injuries or joint changes in your 20s, you generally get your bone can repair. You call it wear and repair. We don't call it wear and tear anymore, because it can repair in some cases. But with gout, that's not always the case, and it does need, for some people, where they're more susceptible, lifelong treatment. So, like, again, it's one of those things that we do know it's linked with metabolic health. So if you're thinking that you've got it, it's good to get a good health check, and you do need a lot of GP involvement. So the podiatrist is there to help you manage it, but make sure you're signposted early. And we see enough gout, because it primarily affects the feet, that we're really good at spotting it. So if you're unsure, get yourself to a podiatrist.
Thank you. I think that's a good place to bring this to an end, to try and keep this in under 30 minutes around that time. I just want to say a massive, massive thank you for coming on, and hopefully you'll come on again, because there's so many more topics I want to discuss with you, and then we can try and have a more stable internet connection as well. But at least we got the audio all sorted.
Yeah.
So thank you very much. So hopefully you enjoyed that episode. Please do subscribe to the podcast. If you have any questions, please let us know, and we shall see you on the next episode. See you later. Bye.
Thank you. Bye.